to let you guys know we are recording. So this will be recorded in case you are not able to stay the entire time, or you have a friend or a classmate that wanted to come but wasn't able to actually attend. The good news is that this recording will be available on the Sociate YouTube channel probably by Friday the latest. So with that being said, I'll just mention a couple of ground rules before I let Randeep kick it off and introduce Christine. There are pretty much almost no ground rules here, just other than please feel free to put all your questions in the chat. We will try to get to your questions, or as many of the questions as possible. As I see more people are trickling in, it's possible that we may have more questions than time. But if I start seeing that there's a lot of questions in the chat, I will cut my handful of prepared questions short, and we'll let the audience Q&A take over. And of course, I'd be remiss if I didn't mention that if you are an MBA student or an MBA alum and you're not already a member of Sociate, which is who's hosting this event, I encourage you guys to sign up, and we'll certainly share the link with you guys afterwards, or Randeep will put it in the chat. So yeah, without further ado, Randeep, if you want to kick it off, that would be great.
Sure. Thanks, Marcy. Well, thanks everyone for joining us this Wednesday, and thanks to Christine for joining us this session. This is our 8th session. I'm just giving a count, Marcy, so of a live Q&A this year, and more coming in the coming weeks. Christine is the CEO of Origin Healthcare and also an Yale MBA alum. So Christine, welcome to the program, and I will let Marcy ask the initial set of questions, and then we'll open it up for the rest of the audiences to submit the questions in the chat forum here. So Marcy, Christine, you want to start with a brief introduction about yourself, and then Marcy can ask the first set of questions.
Sure. Thanks again, Randeep and Marcy, for having me. I'm really excited to be here. Thank you all for attending. I'm sure it's been a long day for you all. So quick bio background. Let's see, I went to Stanford University for my undergraduate. I did my medical school at the University of Colorado, and then went to University of California, San Diego for my internal medicine residency. I stayed on for a chief resident year and then moved to Arizona to start my medical career, and started as a hospitalist physician. So a physician that specializes in taking care of adult patients in the hospital who are being admitted to have medical treatment. So anyone that's not having a baby or having surgery would be sort of in the purview of what we would take care of. During that time, really started thinking about, gosh, if I could run a program, I would do things a little different than the group I was with, and then moved to Colorado. I started a hospitalist program there. So I was the single founder and ran that company as the CEO for 16 years. And then I think we'll talk a little bit more, but most recently left that company and started Origin Healthcare at the beginning of 2021.
Thanks so much. That was an excellent overview. And like you said, there's so many things we can dive into here. And a couple of these, won't be surprises, because I know we mentioned that we would chat about them, but I would love to understand a little bit more about your current company and your current venture, Origin Healthcare. I know that we tossed around the term when we initially talked, the hospital at home model. And so I was thinking maybe you could share a little bit about that and what that means, and we could take it from there.
Mm-hmm. So really building on my career as a hospital clinician, while I know that hospitals have a really important part in taking care of patients, they can also unfortunately be problematic. Patients can get infections, get confused, separated from loved ones. And of course, as we know, all of these things and many more got worse during COVID. When I was looking for what to do as my next step in my career, came across the hospital at home model. And this was something that actually had been used around the world for decades. Multiple countries like Australia, Italy, and Spain have been doing this. And then here in the States, there were really rigorous clinical trials. And essentially what the trial showed is that there are about 30% of current adult inpatient medical patients who can't actually be cared for at home. So especially with some of the technology advances that we have in place for monitoring, and really just a little bit a better understanding of patient safety, those patients being cared for at home are experiencing significantly better clinical outcomes, better safety, quality, obviously a better patient experience. And then it was at 30 to 40% lower cost of care, which I thought was going to be a game changer, where you really saw perfect alignment of what you would really want for a healthcare system, better outcomes for patient, lower cost of care. And so that's what the hospital at home model is doing, is shifting those patients that we know historically can be cared for at home and moving them out of the hospital and providing that care in the physical walls of their house.
No, that's excellent. And like I said, since I do not come from a healthcare background, and like I'm sure a lot of the people on this call today, this is all very eye-opening to me, and I'm still continuing to learn more about it. One thing I also would love to do is just kind of level set with everybody, kind of where you and the company is at this point in time. I would love for you to talk about, the kind of the number of employees, where you're at with raising money. I know we also talked about it that you officially already started treating patients as well. So not to steal your thunder, I'll let you go into that. But yeah, if you could tell us a little bit about like where you are in your journey.
So we officially started working on this full time in January. We had to basically operationalize a hospital. We didn't want to shrink a hospital and just put it on a smaller footprint because we really wanted to innovate and care, but had to get everything that we needed to be able to provide care safely at home. So we treated our first patient in April. We currently have 10 employees on our staff. So our clinical team that goes into the home will consist of a nurse and a nurse practitioner. And then we have physicians who are doing telemedicine visits in addition to the in-home visits. So predominantly our staff right now are clinical staff. There are 3 co-founders. In addition to myself, I actually have 2 co-founders. One is our chief quality officer, and then one is our chief nursing officer. So we've been doing pretty much, as I'm sure any of you that have been in the startup world, you're chief cook and head bottle washer. So you do a little bit of everything when you're a co-founder. So we're seeing patients as well as doing payroll and some of those other pieces. A lot of what we're concentrating on, we're an independent company at this time. And so it's really trying to align with the stakeholders. And a key part of this is obviously alignment with people who pay the bills for healthcare. So a lot of networking in order to get those contracts in place. We have currently signed 3 self-funded employers, which we can talk about, why we took that tactic to be able to provide these services to their employees. And so we're starting to see some momentum build. I have bootstrapped the company up until now for various reasons as well. And we're looking at this point as we're growing and scaling and really the opportunity for hospital at home starting to take off. We are looking at officially starting a raise, which we feel like would be at a seed level, having, gotten ourselves through the MVP. And so we're officially looking to raise. We had just been recently at a meeting where we made a lot of contacts with some venture capital firms. So hopeful to have some outcomes from that coming up. We are hopeful with some of the things we have on our plate that we'll be looking to hire. So we haven't officially started to hire, but as you are sitting here listening to this, if there's anything that you hear that resonates with you on the mission of why we're doing this and what we're doing, would love for you to reach out because we expect to have some opportunities opening up hopefully in the near future.
That's great. Thank you so much. And yes, I know we had spoke about this as well. So I'm sure you will absolutely be having some people take you up on that. And certainly once you have positions opening, let's say next year, and you have those recs available, please feel free to, share them with us, put them right on Sociate, whatever makes sense for you. But I'm sure you'll have a number of interested parties here.
Thanks.
Yeah, and we can get into more of the partners and why you did what you did. But I think that I would also like to make sure that I ask, so how has the pandemic impacted or accelerated your business model? I mean, you started this business in the middle of a pandemic. It is a healthcare related business. So for better or worse, how has it impacted you?
I think it's probably a coin toss at this point. When the pandemic, we were exploring this model of healthcare before the pandemic. Actually, we thought this was a great idea even pre-pandemic. And then of course the pandemic hit. And in a lot of ways, it's accelerated. I think the thing you'll hear commonly, it's unmasked a lot of the problems that were already in existence in healthcare and brought those to the forefront and created opportunities for people to rethink, how are we addressing access? How are we addressing equity issues? How are we, as we're structuring companies in healthcare, how are we making sure that we have a diverse workforce that really honors the patient population that we're treating? Is that representative of the workforce? So many issues that came to front. So I think those things have definitely helped. I think all of us in our MBA programs have seen, in our macroeconomics, the shock curves, where you see the massive shifting. And so this was really a rare event in healthcare to experience a shock, right? Healthcare has been one of those, no matter what happens in the economy, healthcare sort of steadily plods along. But this was unlike an event that we've ever seen before. And I think it's created opportunities for people to rethink that. On the flip side, from a very basic operational level, what it's also done is it just made it harder because the people that you need to align to innovate a model in healthcare are just so busy trying to stay afloat, right? Just take care of the issues they have right in front of them. We would have meetings with executive of healthcare systems, and then those would be canceled because the vaccine mandate was coming out, and that created a whole set of drama in the hospital, and that was the burning platform that they had to manage, PPE shortages at one point. So there are a lot of other things that I think it's really hard for people that are in healthcare right now managing through a pandemic to lift their heads up. It's also the time, I think, though, that we've learned, like, if you don't plan ahead and you don't think proactively, we see the problems that can come into play. So I'm really hoping that when people can't take that breath of air, that they see the need to really divert some resources to planning ahead, even once we recover from the pandemic period. So I would say it's probably a coin toss at this point.
Well, I think that makes a ton of sense. And like you said, I kind of, that's the perfect way to put it, that there was a shock to kind of the healthcare system and the healthcare industry as a whole. So I think, like, anytime anybody starts their own venture, no matter what, you're going to have your ups and downs and the positives and negatives, but you had kind of these extra external forces that you have no control over at play here. And even though you probably think you figured a lot of them out, I'm sure there will continue to be, especially as you guys are growing, a lot more surprises along the way, for better or for worse. I think, kind of on a related topic, I think people are always interested in hearing about some of the challenges that you faced while, either if they can be healthcare specific to your business, or just in starting your own business in general. And also on the flip side, then, what are some lessons learned as a result of these challenges that you faced?
So we only have 45 minutes, and I could probably
That's
talk
okay. People
for
are being
longer.
too shy. We need
just on that
questions in the chat. Don't let me keep asking them all.
Just on that question alone. So, again, context. I founded another company. I ran that company. It was never set up to be a company that would scale, that would require investment capital, that would IPO or undergo M&A. Part of going to Yale was to really understand a side of business that I had not been exposed to before. So that is definitely a steep learning curve, is the investment piece of this. If you're creating a startup that you intend to actually rapidly scale, making sure that you use your resources and your network. And we can talk about that a little bit more. I think some of the other challenges have really been, again, the theme of this being a mission-driven entrepreneurship. The mission part of why I'm doing this, honestly, why I left a job that paid really well in a position that I was very comfortable with to bootstrap a company and not get any salary for going on 10 months right now. Many people would say that might not have been the smartest decision, but you have to feel passionately about what you're doing. And I think sort of the larger theme is that healthcare, there are certain industries that are very hard to innovate in. And healthcare, there's a reason that healthcare has been broken for as long as it has been, is that the incumbents in healthcare have a really strong hold on the way healthcare is delivered right now, and change is very difficult. And again, we're an independent company. We're not tied into any one payer or any one health system. I definitely acknowledge the bias that I have of running an independent company before, that I feel that is the best position for us to be in, so we can make a decision that's best for patient care and not be beholden to any hospital who says, well, we'll make more revenue today if we bring this patient into the hospital than if we send them home, because there's, conflicting interests sometimes for the people that are already there. So we believe passionately that this is the way that this model of healthcare and innovation in healthcare should be delivered, but it is definitely puts you at a disadvantage in coming in and having those conversations. Hospitals have played a very dominant role in how healthcare has been delivered in the past before. I think they're not going to have that luxury moving forward with all the activity we're seeing in healthcare innovation, digital tech, and really the retail giants coming into this. So I think that that day and age is going to change. And you and I have talked about this, what will happen to hospitals if they don't adapt is that they'll become the blockbuster of healthcare, and they'll be left with all the uninsured and high complex patients. And so you see this ahead, and you want to be a part of helping the healthcare systems adapt to change, but it's a matter of just being patient. And then the last thing I would say that's a challenge, I think, and again, for any of you innovating, especially in healthcare, is I think we all have to be mindful of, you start up a company and they tell you to be laser focused on what you're doing, but also be mindful of how you then are positioning yourself in the greater landscape. And what I worry for patients is that we're creating a more fragmented experience for them than they already are seeing at this point. If there's a clinician that they see for their primary care visits, but just Monday through Friday, and then they're supposed to call a different telehealth service at night, but someone is managing their diabetes, but they're doing that through, remote monitoring, all of these things are going to make it very challenging for patients to understand who they're supposed to contact. And we've already struggled with sharing information within healthcare systems. What happens when someone's getting care at Best Buy and then has care somewhere else? How are we going to make sure that we're providing safe and efficient care for patients? So that's something that is very mindful as we're developing how we want to be positioning ourselves. And I would just say to anyone that's specifically looking at healthcare, always make sure what you're doing is keeping the patient at the center as you build.
That's great. Thank you so much. Those are all kind of, I think, fantastic insights, and keeping the patient at the center of or top of mind or center of what you do. It seems like it should be obvious, but I think as we see with a lot of healthcare ventures, big and small, new and old, that isn't always the case. So it's very refreshing. And I'm sure a lot of people also feel this way, to kind of hear that that's at the core of your business and what you're aiming to do. So Rebecca, I wish we had prizes to give out, because I would give you one for being the first person being brave enough to ask a question. And you have several great questions, so I don't need to read them for you. Feel free to come off mute and ask these fantastic questions that you have here.
All right, I will. Hi, Christine. I'm a 23 EMBA, so nice to see you.
Nice to meet you.
I'm a registered nurse by licensure, and I've worked in hospital leadership as a manager of a couple of departments over time, and also feel like there's some changes that are brewing, and how do we best leverage that? So a couple questions that I have for you is, how have you worked to solve the problem of funneling patients who are appropriate for this type of care into the business? Are hospitals at this point making referrals? Is it self-referral through family members or other advocates who are seeking that care for their loved ones? So that's the first question, and I'll let you answer that, and then I'll get to the next one.
Sure. The way our current model is, we can take a patient from any avenue as long as they're referred by a clinician. The regulatory space for hospital at home is pretty gray right now. In fact, there really isn't any oversight of hospital at home. We know that that's going to be coming, and we've been very purposeful about building our model so that it reflects really all of the same criteria that a hospital would be beholden to as far as reporting and regulations and compliance. And one of those being that the patient has to meet hospital admission criteria, whether that's through Milliman or Interqual. So patients shouldn't self-refer into that. So we want a clinician to basically say, we see a patient, and if Origin Healthcare wasn't here, I'd be sending them to the emergency department, or I would be directly admitting them. Also to make sure that they're not at a decompensation period that might mean that they need step down or ICU care, in which case those patients should probably be admitted for the first day or two. Beyond that, we can take them from primary care, specialty, ED, something they call an early discharge. So they're in the hospital for a couple of days. They need 3 or 4 more days of antibiotics. Let's move them to home and finish off their antibiotics at home. So through any of those avenues. CMS, so Medicare, has a waiver in place, which is also creating a lot more activity or interest in this space as of November. They're actually permitting hospital care at home for the full rate that they would otherwise receive if they were in the walls of the hospital. The caveat being for this, and so a problem for an independent company like ours, is that it actually has to be applied. A hospital has to put the application in. They can subcontract out or do it all themselves, but the hospital has to apply. And those patients under the waiver can only come from an ED or a current inpatient. So unfortunately, a little bit more narrow opportunity. Our hope is that once the PHE expires and CMS looks at the outcomes from this, so they'll expand that, because I think the opportunity to avoid the emergency department for various reasons, the cost of ambulance transfers, the emergency department already being overcrowded, it would be great to take patients directly into the home.
Thank you. My other question is, what changes do you think kind of need to come in the future to make this sustainable in the long run, to make this a standard part of the healthcare landscape in the future? I think that it definitely has a place. And, so being within nursing, we know that staffing shortages are a significant piece. Obviously, there's trepidation surrounding if a patient's hospital worthy, and they need that level of 24/7 care. How do you make sure that they have the appropriate resources available to them when you don't get to kind of pool those resources in one physical space? So maybe that's a two-part question.
Probably a little bit of a two-part. I think to quickly answer the first piece, to make this sustainable, we need the payers aligned. So we need Medicare to ultimately say, hey, we're going to make the payment permanent. The private payers coming on board to follow for reasons that are still entirely unclear to me. The private insurance companies drag and wait for Medicare to make a lot of decisions. So I think, if Medicare were to make this permanent, similar to some of the exceptions that they're making permanent with telehealth, then that will make this. I think, there still honestly is the piece though of the conflict of interest. And, just because Medicare makes it available, will hospitals actually provide this? I truly believe, I told someone if I told you that I had a medication that made you safer, that you had a better experience from, that delivered higher quality outcomes at 30 to 40%, like everyone would be, give me that medication. And this just is something I struggle with still, and that this has been rigorously proven to be better. And yet hospitals can make the decision to allow patients to choose it or not. That being said, I still think patients should have the choice. So even if a patient met criteria, absolutely, they should choose whether they want to get the care at home or whether they want to be in the hospital. As far as the other pieces of it, I think that a part of it, I would just tell you an anecdote. Our CNO, her whole career has been in the cardiothoracic ICU at UCLA. So some of our patients, she's been asking, she's like, would this patient be in the hospital? I was like, yes, welcome to the medical unit, right? This is, we say a patient's getting 24/7 care, but most of the patients on the med-surg units are being monitored with maybe every 4 to 8 hours getting a vital sign. If you're in there and you're getting an antibiotic once a day, the staff's probably in there for a total of maybe 2 hours of total care. And so some of it is saying that there's a lot of waste and inefficiency in having somebody in a bed, and you're paying for the brick and mortar cost and the 24/7 staffing. Neutropenic fever patients waiting for blood culture results and getting once a day antibiotic, they are much safer at home than being in the hospital waiting for those. So I think we're talking about that patient population that isn't requiring 24-hour telemetry monitoring and continuous infusions. This is really the patients that are getting, for all intents and purposes, a couple of hours. Our remote patient monitoring allows us to actually monitor vital signs and have that connectivity piece, so that patient can get a hold of us, and we have response times to get physically into their home or available 24/7. So definitely looking again, and all of the outcomes that we have quoted previously, again, have all been set up from studies that show a similar setup. And so we know, again, that that's safe. There will be some patients that escalate back to the hospital inevitably, much as it is in the hospital when you get admitted to the medical unit, is there's occasionally patients that will end up in the step down unit from the floor. And speaking to Bruce Lapp, who is one of the gurus of this, he says, if you don't see some escalation of care, you're probably just decanting urgent care level visits, right? And so if you really want to create a model that's going to change the face of healthcare and change the way that hospital systems are built and structured, then this is going to be something that you're going to probably anticipate. The workforce shortage, last thing I would say really quickly is, yes, there's no denying, I think this is a cataclysmic event for the healthcare workforce. Barring everything else we're seeing with the pandemic. And in fact, our belief is that people still want to take care of patients. They still want to be in medicine. We have just made the way that we've structured their ability to work and provide care so untenable by making it so burdensome for administrative tasks, by really disconnecting them from caring for the patients. We had an article come out in a local paper, and within 24 hours received 6 job inquiries from nurses, nurse practitioners, and physicians, because people connect with this level of care. You're going to be one-on-one with the patient in the home. You're going to be able to see environmental factors that make an impact in their life. So you're not just putting a Band-Aid on that medical illness and expecting you're going to see Mrs. Jones back in 3 weeks. So this is that reconnect that we think people in healthcare are really going to find meaningful. So we actually believe that we'll be able to still staff the clinical component and keep people engaged in healthcare. Sorry, that was a lot in one answer, Rebecca.
That was a great answer. Thank you so much.
No, Christine, I love it. Your answers are very thorough, and like I said, I'm continuing to learn from all the different questions and answers. And actually, just going back to market share, and I think you and I might have even touched upon this a little bit as well. So, and I apologize if I say your name incorrectly, but Thanasak, I saw that you had a question here in the chat. I didn't know if you wanted to come off mute and ask Christine directly.
Yep. Hi, I can come off mute. Hi. Yeah, so hi, Christine. It's very, the concept is really interesting, and I find it very inspiring, you know, and in the long run, I can see, you know, in like 10, 20 years, I can see how it can change the face of medicine. I'm just wondering how big the market is right now, and is it a little bit early to start a company? That's because, you know, if the market is not ready, it could really takes a long time to kickstart something. Yeah, so that's
great question. I can give you the math on the market and then answer your question about, you know, is the timing right? Because I think that's really the bigger question. So looking at the studies that show that about 30% of our medical patients could be cared for under that model, currently looking at the admissions to the hospital, this is about 5 million patients a year, that if you transferred all of them to the home, the TAM on that actually is about $40 billion. So it's a significant market opportunity, and really strong unit economics, which again, I think reflect, you know, unfortunately, how much waste there is in the current healthcare system. That number we know is going to continue to grow. It's one of the discussions we have about proactively planning for healthcare systems. So by the year 2030, we're going to have 30% more people over age 65. Our current healthcare system is not currently built to manage another 30% of patients, right? These are patients who are going to be living longer, who increasingly are more tech savvy, who are asking to get their care at home. It costs $2 million to add one hospital bed to a facility. So if you talk about saying we want to build, so a hospital shouldn't be a destination, it should be a level of care. So those hospital treatments should extend out into the community. So if you want to build flexible bed capacity that not only gets you through a pandemic, but really allows you to say, where's the best use of capital expenditures, is adding a physical bed on to manage that 30% growth, where then we're sort of driven and beholden to keep those beds full of patients. Is that the best way to manage this healthcare system moving forward? So I would say that to me, it makes sense to be building that capacity now. Your question about whether it's too early is a great question. There are times where I think we're late. Like there's so, I mean, clearly we have in the area where I'm at, and I apologize, I think Marcia told me I'm in Colorado. So in the Colorado area where I am, we have for the last 9 weeks canceled level 2 and level 3 surgeries here. So anything that's not trauma or, you know, something very emergent, those patients now are not getting the care. We already know what happened when we canceled surgeries the first time around. So in some ways, I think we're too late because we haven't built the system to manage that capacity adequately at this point. But to the other piece, I'm not going to deny, I mean, it is still very unclear, especially with the approach that we've taken to or stay independent, whether or not the big people that we need to get aligned, the payers and the hospitals, are ready for this. I do think that it's coming. I actually don't think it's that far away. You know, of course, I filter to what I see, but when you see, you know, Best Buy, you know, buying up this very big remote patient monitoring company, when you see Amazon spreading, with Walmart doing, it's inevitable that they're coming into the home. There isn't probably a LinkedIn post that doesn't have anything to do with home at this point. I think being independent, again, makes it a little bit harder to do. But what we're also finding is that because we're independent, because we can bring the clinical team in, that goes back to why we've received traction from the self-funded employers. So the self-funded employers, basically, if you don't, some employer groups have said, instead of paying premiums for my employees, which I'm just, you know, paying regardless of whether they use healthcare, I'm going to sort of pool a bunch of money where I'm going to pay out of that pool all of the healthcare cost up to a certain amount, and then they get what's called stop loss after that, so they don't bankrupt themselves. But they basically have to manage that money appropriately. And if you can say, this is not an added cost onto your employee benefit plan, so it's not like adding a gym membership or a wellness coach. This is basically an exchange. So you have a patient who's going to be admitted otherwise, they'll be admitted to our service 30 to 40% lower cost of care, better outcomes for where they want to be. This translates very well, and it's going to let some of those companies stay more competitive. We're putting more and more pressure on employers to manage healthcare expenses and not giving them the tools and resources. So we're seeing that. And again, my last thing that I would say is that 30 to 40% savings, right? That's savings over what? So the average commercial payer pays 189% of Medicare costs for a patient. In the Northern Colorado region, they pay 330% of Medicare. The regional variation in commercial rates is unbelievable. And so there are definitely markets where this is going to resonate quite quickly. And so that's where we've started to concentrate our traction on. And then I think, bringing the patients in, empowering them with the voice to start saying, why don't we have this option here in town? This is something, talking to patients and their families about some of the struggles, knowing that there are patients out there that regardless of the system don't feel like they're welcome in a hospital. So don't come and get care unless they're super, super sick. We're going to be able to meet them in an area where they feel more comfortable. Well, they're going to, be able to extend trust to us to come into their home. We're going to be able to provide care to patients who currently aren't getting care. And I think that opportunity needs to be available.
Right. Thank you. Are there any other competitor that are already doing this in the market, and like other organizations that are doing this?
Mm-hmm. So for anyone who's interested, there's a group called the Hospital at Home Users Group. They actually have their third conference this Thursday. That was set up by really the sort of thought leaders in this area. So Mount Sinai, the Brigham, Mass General, Johns Hopkins, these academic institutions that really had been doing the clinical studies since the 1990s and have been keeping this in play. And there's integrated health systems like Marshfield, Albuquerque, and New Mexico, who are the payer and provider. So they didn't have to worry about getting anyone to agree to pay the bill. So they've been doing this for a while. There are three other sort of independent competitors, and Medically Home is a big one. They're out of the East Coast, and they partnered with several systems, most notable Mayo and Kaiser Permanente, which is also one of the reasons I think this will continue to be permanent. It's hard to get the Geisingers, the Mayos, and everybody doing this and then tell them later that they can't. There's another group called Contessa, which recently was bought out by a large home healthcare agency called Amedisys. So there's already been some M&A in the space. And then Dispatch Health, which is actually a startup that started down the street from me down in Denver. They started as a mobile urgent care company and are most recently getting into the hospital at home space. So those are three, if you're looking up others that have been doing this. And I think, again, with the systems that they're currently partnering with, this is just going to continue to bring traction.
Thank you for very comprehensive answers.
You're welcome.
Thank you. Thank you so much. And now I can definitely say that I can understand now why you said, oh, if anything, I'm late. I wish we had started sooner than this. Now, I didn't know that there were so many players out there either. So I had no idea either. So that's very, very interesting to learn. And yes, Srini, I know you asked about the conference name. Before we go to Tom's question, perhaps you could just repeat the conference name, and I can also send that out in an email after too. But
yeah, it's called Hospital at Home Users Group. I think if it's probably www.hah-users-group. Okay. And I'll double check that. But yeah, they're doing a pre-conference on Thursday. That's part of the Academy of Home Care Medicine conference that occurs on Friday and Saturday.
Thank you. So yeah, I would love for Tom to ask her question as well, because this was something that was on my mind as well, and I'm sure a number of people are thinking it, and I'm sure you have a very interesting answer to it. But Tom, yeah, if you want to kind of elaborate on your question, you'll do a better job than I will.
Yeah, hi. Thank you so much for hosting this. This is really awesome. I wanted to ask how are you going to create trust with patients that they're going to be able to get the same care? Because obviously my house is different than a hospital setting, both from staff, machinery, I know, like whatever, and there's still some perception around that. And then on a very rude way, I'm going to ask as well if you're going to like approach the pediatrics patients, because that's some of a personal interest to me, and we can go offline with that.
Yeah. So for the first question, as far as trust, absolutely, that is a really important piece. I think One of the ways that we do this is that we have been talking to the providers. So one of the reasons we launched here in Northern Colorado is that I have worked here for 16 years, had launched the hospital medicine program. So I had the relationships with providers. So, people rely a lot on their clinicians, so doctor and PPA, whoever it is, to make recommendations. So we need to make sure, so I've been marketing, going to every PCP office, specialty office, ED. The data on this is just so robust that it's so hard and it's undeniable. I think, there were studies done by, it might've been the Brigham, that showed, when patients were offered, it was 70% acceptance rate, and that was pre-COVID. So one would expect that that number was even higher. And so I think, having the provider piece of it, also just when we go into the home, we're in the home probably at least 2 hours during every visit. So we're taking time with that patient. We're going above and beyond. We're screening for social determinants of health with every patient. Even if we physically see something that we think this person can't possibly have any needs, we don't want to interject our own bias. So we're screening every patient. We're taking their food out of the cabinet. We're learning about, so in those interactions, we're spending more time with a patient than I guarantee that they're getting in a hospital setting, and probably from the primary care team. Again, primary care is just so busy and so burdened. Every patient we've treated, we've discovered something that their primary team didn't know about or suspected, but it was good to actually verify. So I think just the manner of how we're treating and interacting with patients is providing them a whole different experience than they ever have before. The other piece, though, is that I think, we just briefly talked with the last question, is that, probably half of our patients, again, would not have been able to get care if we weren't there. So our first patient, had gained 20 pounds in fluid weight. It was up to 8 liters of oxygen from her baseline 6 liters. This patient should have, been admitted for IV medications monitoring, but was refusing care because she had an adult son at home with mental health challenges. And she said, I just can't leave him unsupervised. We've had patients who have had a loved one with dementia, and if I go into the hospital, they're going to, decompensate. So we're actually providing options to patients that you should see the relief when we actually go into their home. Even COVID patients who have already made the trip to the ER, who are just, doing poorly at home, the thought for them to have to get up and go to the emergency department for another assessment. So it's really opening up avenues, but trust is a big part of that. We're screening patients starting at hiring, understanding that, Rebecca probably knows this as well, that the best clinician on a medical unit may not be the best clinician in a patient's home exactly for your reason. For the most part, those homes are going to be very different than the homes that we live in, and definitely different than the sterile hospital that gets cleaned. The room gets cleaned every 2 or twice a day. So that and the teamwork, we have a very collaborative team. I think in some ways, again, as a clinician, I know I got away from this, is that I'll see patients on the floor and then I'll leave and go chart somewhere else with electronic medical records. So you've really disconnected from the care team. Our team is collaborative. We're seeing the patients. We have huddles in the morning, huddles in the evening. And so it's really connecting that piece for people in a very different way, but making sure that these are people that are going to be able to honor the diverse population that they're seeing and be able to function, in a smaller, fairly autonomous setting.
That's a great
pediatrics really quick. So It goes back to that focus. So my team will laugh because, of course, I have this hey, this is what my 10-year map is. And probably not 10 years, but pediatrics is definitely on my map. As an internist, it makes me sweat a little bit because I think caring for a child, how could I possibly, it wouldn't be me clearly, but I think from what I've heard, the pediatric population there could be cared for at home and obviously would be a game changer for parents, not having to figure out which parent's going to stay with the kid in the hospital and the ones that are left at home. And so, yes, it is definitely on our radar. So if you would like to talk about the pediatric population, please reach out to me.
Perfect. That's great. Thank you so much for sharing. I do have a follow-up question, if that's okay.
Yeah, absolutely. Yeah.
Okay, perfect. I completely get what you're saying about trust and how you build the interaction with patients, and also starting with patients that do not really have the option of going into a hospital, which is makes total sense. But I'm also wondering, and you mentioned that you're starting in your hometown because you know the providers and you know your community. How do you make this business scale when the network is bigger to other cities that you don't have the same network? How do you plan to approach that?
Yeah, the scale, there's so many things to consider about the scale, and that is really will be the differentiator here. From the trust standpoint, obviously having done this, we would say probably our first patient would have been the one that's But luckily we're out of our first patient. We're into double-digit patients at this point. And so I think, we're being very cautious about, again, as I talked to Rebecca, setting up so that all the compliance exactly mirrors what you would see in a hospital setting. We're CMS or Medicare under the waiver only requires 3 metrics to be reported. We have a dashboard of like 26 different metrics that we're following. So we want a lot of transparency into this. And once we've been able to demonstrate that, I think going into the next community is going to be easier to say we have a track record in place. I think it will also depend on those key partnerships. If we could get a national payer where we're piloting here, and then we can just translate with that payer into their next market opportunity, that will make a difference. We're clearly looking for healthcare systems that are ready to innovate and adopt this model. And so if you have a healthcare system that's backing you and you come in, and again, we're trying to bring the functionality where we can either bring our platform or bring our platform and clinical team, depending on what the community wants. So it's really establishing those partnerships in the next community. The other issues as far as scale just have to do with, a lot of what we're doing right now is Excel spreadsheets and Microsoft Office. And, how do you actually take some of those? We're putting in a lot of time. Part of being a startup and probably growing slower than we would like is that we have time to put policies and procedures in place. And then we knew that we would find areas where IT development would be key. And we've figured out what that is. We've actually run it by a couple of people. It's not something this is actually, we're now IT play, which I think, goes back to clearly VCs are more interested. If you have some IT component, they definitely like the shiny tools in addition to the service piece, but this will actually allow us to scale our workforce efficiently, work on risk mitigation, and then would possibly be translatable, I think, across other mobile healthcare solutions such as home health, hospice. But great question.
Awesome. Thank you so much.
You're
I know
welcome.
that to reach out to you on that, Pete.
Okay, sounds great.
Fantastic. And I see we got another question in the chat from Sarah. So please feel free to go for it.
Thanks, Marcy. So I was just trying to get an understanding of like how this service works on the day-to-day. So I was thinking about your staffing. So how many professionals are required on each team, and are some of those professionals physicians, and how do they contribute full-time or part-time, and what are the challenges that you face with staffing?
Mm-hmm. So the staffing right now, we've set up our in-home team to be a nurse and a nurse practitioner team. We have the flexibility that we may also, depending again on the market and how the workforce staffing is, RNs are definitely the hardest workforce to find for a lot of reasons, as we talked about. But having even a paramedic and an NP in the home, so we have that flexibility. The physician, separate from right now, as a founder and as the clinician, I'm going into the home in a lot of these visits because I want to see what we're doing and things in action, but the clinicians are meant to be remote. We're looking actually at having that team that's in the home see 5 patients a day. So if you're going to spend 1 to 2 hours with the patient, we want to be able to have the patient, or excuse me, have the team be able to have that time, be able to commute effectively across the map, which is always one of the inefficiencies. And some of that depends on, what your traffic pattern is like and how busy your town is. So we're looking at a 5-to-1 ratio for the in-home team, and for our telemedicine physician visits to be on a 10-to-1. Actually think that number could probably increase, but we're using our clinicians to make sure that the warm handoff, so the verbal handoff to the outpatient team is made. So our physicians are doing other things outside of their telemedicine visits, doing some of our quality tracking. So that is in play right now. I think that the challenges for the staffing come back to what we're talking about with Rebecca is, we have our thesis and we've seen so far a ton of interest beyond what we can even employ right now. Will that be translatable moving forward? How do we make this a meaningful place for people to work? Again, I think removing a lot of those other things that have previously been barriers. Even when we are talking about developing our IT solution, we said to the tech person, we're like, we don't want 35 logins for, this login for this platform and this login. Like, we are being super mindful of how we actually take away the burden and let clinicians practice clinical medicine. There was another piece to that, Sarah, and I forgot. Did I answer?
No, that was pretty much it.
Okay.
That's amazing if you could have a team service. You said 5 patients a day.
Yeah, and again, we've done our pro forma, and granted, I think again, what I found funny when I started taking the entrepreneur finance classes is that there's so many things we do that everybody kind of like winks the 5-year pro forma for a startup is completely pie in the sky, but yet we still have to do it to show people. But even not at the 5-year pro forma, looking down, we can staff that with very competitive salaries and meaningful job interaction, because you're just working more efficiently. Because again, there's all that extra cost in healthcare. I think when we develop the IT piece on it, it'll actually even add an additional layer on top of it. So it doesn't make sense to any of us, I think. And it's the question that I definitely get repeatedly is, how can that be efficient when you have people behind the windshield? People say windshield time is non-reimbursable time, and yet it still is, right? Again, we have all of these robust studies that show moving people around and different environments. We had people in different levels of city. I think the big question as we move is, how do we include those communities that haven't been studied? Clearly, innovation happens a lot in dense urban areas, especially when you're looking at going into the home. How do we capture the rural communities that continue to be neglected in standard healthcare and definitely in healthcare innovation? And we're actively looking at having conversations with critical access hospitals. The model will, by nature, have to be very different given the remoteness of it, but I still think it's possible. And I want to make sure that we're incorporating 20% of Americans live in a rural community, and yet they have fewer and fewer access to healthcare. So I think we have to be thinking about those and not just going where it seems obvious in the beginning.
Great. Thank you so much, Christine. I will probably, unless a couple more questions pop up in the chat, I had a couple more topics I just wanted to, these are more general, more about entrepreneurship in general. And I think you and I probably chatted about them a little bit, but I'd love to ask them here. But oh no, we can answer before I ask my question. Aishwarya, why don't you ask your question? Not a word. The EMR. I don't know if that exact question hasn't been asked.
Hi. So great session. So I just actually want to know. I missed the beginning part of it, but so the patient care that's being handled at home, is the information integrated into the hospital's EMR so that, say, the regular healthcare provider also has information to it? And also, like, say, some patients need, say, frequent, for example, they may need to get the electrolytes tested frequently. So do you all use point of care testing for that? Or is it that you'll draw blood samples, send it to the hospital lab to get analyzed? How does that work?
And then your first question with the EMR, yes, we're using Athena as our EMR. Epic is obviously probably one of the biggest ones. To be honest with you, it was cost prohibitive as a startup to use Epic, but the Athena platform actually integrates into Epic through the Care Everywhere tab, however familiar. So all of our notes are viewable by all the Epic clinicians in town. We have it set so our daily progress notes are actually pushed there, as well as our discharge summaries. The patient also, we have it set up to push to their portal and their email every day. So both the patients and their assigned primary care team, or whoever they want us to be listing as their care team, gets all of that information. So yes, I think integration is a big part of this moving forward. To be fair, if anyone has interest in developing an EMR that's specific for hospital at home, huge opportunity there, because there's the outpatient EMR and the inpatient EMR, and then there's this big gap in between. So we've had to optimize. I think that has been if you listen to the hospital at home user group, they have webinars that you can listen to. I think universally it's what everyone struggled with. So some have taken the inpatient and then turned off functionality. So there's this big white space for any EMR interest. As far as labs go, we have some point of care lab testing. The BMP was cost prohibitive also for us to buy at this point, shockingly enough. So we can do everything else bedside, and then we've contracted with local labs. So we'll draw those labs and drop them off. We have it set up. We're really trying to provide as much flexibility as possible. So if we have a patient that needs a lab draw and we're on the other side of town, we've actually contracted with home healthcare agencies where they can send a nurse in to draw the lab for us. We have a courier service to drop off labs if we need to. So really depending on what's the best use of our clinical team's time, we want to build in that flexibility as far as that.
Thank you.
Thank you. Just one question as an aside. How do you think this model would work with, say, places with less access to medical health care, for example, say some of the more rural areas? So would this model really work for that, especially if you say things like you would have them going home to home, or you'd have them take the blood samples and drop them off at local labs, which may not be available? So you think this model would work? It would need some tweaking?
Yeah, it'll need some tweaking, sort of to the point that we were talking about. The model right now is, to have the density of population in an urban area, it makes some of the scalability a little bit easier, but we're very mindful of that. I think the things out in the rural communities, clearly one of the things, if we're using technology to monitor patients is, we hear it, broadband, right? So what type of ability do they have in order to get service, whether, Wi-Fi or cell service depending on their remote monitoring. So I think some of it, some of the programs that are in play right now will only take people in a 5-mile radius from the mother hospital. I think I describe it to people like a jawbreaker, if you've ever seen those. So you might take higher acuity people within the core of the jawbreaker and maybe a little bit lower acuity farther out. And maybe out here, you need to make sure that you're bringing in your high tech, right? That's 24-hour continuous monitoring, not the one that cycles every 2 hours, so that you can really keep an eye on patients. And then clearly partnering with the community. I mean, I think you hear so much about, the paramedics in these rural communities that are left to providing all this care. So I think we would want to partner with, instead of maybe having our own nursing team do the visit, can we partner with the home healthcare agencies that are in town, with the paramedics that are in town to provide that care? So it would be partnerships, maybe not having the on the boots ground, but doing what we need to do to, again, I think what we want to be mindful is we have no desire to go out and close down a rural hospital. We're not trying to substitute and shut down any hospitals. We really want to augment the care that's out there. And so that would require a lot of partnerships.
Thank you. That's very interesting.
Great. So I know we don't have too much more time, but I did want to kind of ask like a couple of just kind of wrap up, summary type questions, just again, because I know a couple people might not have heard the whole thing. And so one of them is, of course, I would love to know, I mean, you've talked about a whole host of different things that you need to focus on in the near to longer term future, whether it's, expanding into more rural communities, whether it's building out your technology offerings, and you mentioned, so many other things as well. So what would you say, not that you have the luxury of only focusing on 2 or 3 things, but let's just say, what are the kind of the top 2 or 3 things that Origin Healthcare will be focusing on for the foreseeable future? Like, where are your kind of more immediate priorities?
Our immediate priorities are definitely expanding the official partnership base, the contracts, whether through self-funded employers. We've been in conversations with commercial payers, so really trying to finalize a pilot with a payer or a hospital system. So I think, we need that really big catalytic partnership just to grow our numbers even and be able to continue to show proof of concept at the scale that we're wanting to. And then the other piece, I think it really goes back to Tom's question as far as scale, is that I think that tech piece, as we're seeing those patients and developing that tech piece, that's going to really allow us to translate more. So when we come into the next community, how are we going to ensure that interoperability? What are the pieces that are already in play? I hear from some of the hospital at home user sites that have actually applied for the waiver. Like, I had no idea that this was going to be so difficult to manage. I wish someone would just come in and take it off of my hands. And so, can we develop that piece that's 80% done and we can 20% customize it? So I think really getting that platform piece in place.
Thank you. Oh, and Randeep, did you have something to add?
Yeah, actually, I did want to ask Christine. So I know when I'm thinking of home care, I'm thinking also of like home fitness devices and Peloton and all these others. Have you had any discussion around potentially partnering with some of the like fitness devices and things like that? Because it seems like a much more like a natural synergy there. Or is it, you think it's a little bit more kind of fragmented in the way you connect that to the clinician side of it?
Yeah, it'll be very interesting to see what happens in RPM, and the devices altogether. That is definitely a red hot space right now, and so much activity going in. We're trying to find an option that obviously is easy for patients to use, that gives us the information that we need. I mean, we don't want to constantly be in the dashboard. How do we get alerts pushed to us when it's critical? And then again, this is for no denying we are at startup phase. And so we have to be super mindful about the budget. And so really trying to find where those curves cross. But we would love to talk to the right company. We've talked to a couple. We've actually talked to some other people about my whole plea about the EMR, about being a part of that and sort of co-developing in this space, because there's really not, to the point we talked about, less than 3% of the hospitals have any type of hospital at home program right now. How can we be out there giving them back the clinical data that they need in order to refine this? So we're definitely interested. We're actually exploring a lot of those. Where are the different partnerships for people that are doing care in the home that we could actually find synergy with, again, to decrease the fragmentation would be the other goal. So great question.
Sure. Any other questions?
Yeah, can I ask another one?
Yeah, sure, go for it.
I was just thinking about that. How do you refer or like handle with the liability issue?
Say it one more time.
How do you think about liability? Like taking liability on, maybe you mentioned it and I missed it. But
the liability on the devices or just in general?
General.
Yeah. So one thing, the first threshold to pass was, would our malpractice carrier, cover us for the care we're giving at home? And we are covered by COPIC as our malpractice carrier out here. Full transparency of what we're doing, had to speak to their, basically lead physician about it. So we are fully insured to do that. Again, we're licensed and credentialed. In the self-funded employer side, we've had to go through, a lot of them work with something called a third-party administrator, which is typically an insurer that helps with the claims and downstream. So we've actually had 3 different insurance companies through the TPA, vet us and do that as well. So I think the great thing for me, not ever having done clinical research in the past before, is that all the data was already out there. So I think that helped. It was so robust and has been used for so long that it was pretty easy to be able to get that in place.
Perfect, thank you. And what's the best way to contact you?
Marcia, are you sending out information or should I put it in the chat?
Yeah, either way, up to you. I know you're on Sociate, you're on LinkedIn, and it's up to you if you feel comfortable, if you want to share your direct email.
Thanks.
Which, perfect, there you go. And I will also, like I said, after this, and I'm going to ask just like one kind of wrap up question and then let Randeep just mention our next upcoming event and all of that. But I will say actually, so, let me ask my own question before I get away from it. So we always ask this question. This one we ask no matter who we've kind of got on the horn, kind of doing the Q&A. But so overall, and I know this is a huge question and there's a million different answers, but what advice would you give to kind of other, I think there's a lot of MBA students, there might be some alumni on here as well, but any MBAs who are, or entrepreneurs who are exploring opportunities to build their own startup. And in this case, it sounds like there's most of the crowd here is healthcare specific, but feel free to be more general than just healthcare. But yeah, just like kind of any imparting words of wisdom for the crowd.
So 2 things is I would say, if you have an inclination to do it, I would love for you to do it. Anyone needs to, but it sounds like there's some clinical people, and I just so desperately want people with clinical knowledge to be innovating in healthcare. I think it's so important. I wish that med school education adapted a little bit more to generate that interest early on. On the sort of cautious side, I would say it is not for the faint of heart. I will not deny, especially, having been an older student in my EMBA class, you have to be prepared for it, right? People will sometimes say to me, oh, don't you love having free time? I'm like, I have less free time than I've ever had in my life before. I'm just not getting paid for it. I mean, so make sure that you,
these people,
I know, right? Make sure you've done the risk benefit thing. If you have loved ones in your life, make sure that you've talked with them about what that will do. So do that. The other piece that I would say that I think has been most surprising for me, because I would say I'm a fairly introverted person. I worked in a single area for 16 years, is use your network. And that's what's so great. I mean, about this platform period, but being in the schools that you have, is use your network. And even as probably one of the most massive introverts, I have gotten to a point where I will cold email, I will send a LinkedIn, you need to use your network. You will not get a startup even off the ground if you can't do the bold, big moves and reach out to people and ask for help. So anyone that you can reach out to, never pass up an opportunity to do that. And for all of you, you are now in my network. So please feel free, if I can do anything to help and support you, I would love to do that, because I think paying it forward and passing someone along to a contact is a really important part of being in sort of this entrepreneurship space, is that we all need to be in there and help each other out.
Well, Thanks, Christine. I know we are right on time here. Thanks, everyone, for joining. Great questions and great answers. I feel so informed and knowledgeable about this space now. And again, just a quick programming note. There's another exciting Q&A coming up, right, Marcy? In about a month, from a little bit over a month, I guess, from
Wednesday,
now.
December 1st. Yes.
Yes, December 1st. More on that coming soon, right, Marcy? And hope all of you can join and spread the word about Sociate. And as Christine said, use this platform, to reach to founders like Christine and others, and even other peers of yours, to really grow your network. So thanks everyone for joining, and especially thanks to Christine for giving us this great, Q&A.
Thank you guys for coming in, for your amazing questions and interest. Really.
Yeah, Christine, I can't thank you enough. You're fantastic. I knew from talking to you last time. And one thing I can appreciate, even though it's clear that everyone, if not, or at least the majority of the people on this call, have much more healthcare knowledge and background than I do, but you are amazing at also explaining some complex stuff in a way that somebody who's not from the space could understand it. And that's a skill that is extremely valuable. So I appreciate it. But you can obviously get into the weeds with the most technical of them. I don't think I would survive in a conversation like that, but it was definitely a pleasure to have you. And Rebecca, just to let you know, the recording will be available probably not until Friday, but as soon as it's available, we'll be emailing it out to everybody, because we actually had even more people, quite a number RSVP, who just, life happens and couldn't make it. So I know that we'll want to share this with others, and we'll share the link again about the Hospital at Home group. And Christine, if there's any other resources that you think of, you want to shoot me a quick email, I'll add it to the note that we sent out to everybody on Friday.
Thank you all again. Really enjoyed it.
Yeah, thank you so much.
Take care.
Have a great evening, everybody. Thank you.
Is this all that you dreamed it?